Thank you for joining us and welcome to MLI's Community Collective, harnessing the power of the community to battle obesity. This activity is supported by an educational grant from Lilly. This is the second of a three-part series, Practical Applications of New and Emerging Data. If you missed part one, just use the same link that you used to join us tonight, and you can watch on demand at your convenience. Next week, we will all meet together for the final activity in our series, live in person at Bonaventure Brewing Company in the Westin in Los Angeles on Thursday, August 22nd at 6:30 p.m. Our hope is that after listening to both parts 1 and 2, you'll come with any remaining questions and/or challenging cases to discuss. This exclusive event is for you to network with your colleagues so that you feel comfortable making a difference in the lives of your patients who face the challenging cases and comorbidities that come with overweight obesity. If you have colleagues who weren't able to join you tonight, this information will be available to them at their convenience. We'll put that link in the chat, and we'll also include in a follow-up email to you tomorrow so that they can also view on demand prior to our get-together next week. So tell your friends and make it a date. Before we start, let's warm up with a couple of pre-test questions. Please answer on the pop-up. Mr. J is a 50-year-old Caucasian patient with a BMI of 34 kilograms, which is categorized as class 1 obesity. If his waist circumference is 122 centimeters, what is his disease risk relative to normal weight and waist circumference? Okay, next question. The second generation AOM was initiated in your patient 2 weeks ago. They reported that they have been experiencing some gastrointestinal issues. Which of the following is the best way to manage these common side effects? Okay. And the last question. To facilitate shared decision making, what counseling and education points would you provide a patient regarding second generation AOMs, following them to make an informed decision about their therapy? Okay. Thank you all for participating. We will be monitoring the chat, so please feel free to ask your questions there or come off mute and on screen. But again, we'll be monitoring the chat, so feel free to put them right there. So with all that said, it's my great pleasure to introduce you to one of the leading experts in the field of obesity medicine, Dr. Vivek Gupta. Dr. Gupta, thank you for joining us for this series, and I'd like to turn this activity over to you.
Thank you, everyone. Thank you, Marissa. It's nice to talk to you guys again. I was here last week, and for those of you who were last week, this will be a continuation and a good transition, to next week. For everyone who's new, we'll still make this talk will still be very relevant, and we can talk about everything in person next week also. So I'm really excited by this format set up by, the LACMA and everyone else. So I really appreciate this. So I'm going to share my screen. Okay. So, to leave off, to continue some of the themes that we talked about last week, really the big paradigm shift, that has happened in the last few years is thinking of obesity as what it truly is, a chronic disease. Um, this definition, which I love, in that it is a complex, multifactorial condition characterized by excess body fat, viewed as a chronic disorder requiring perpetual care, support, follow-up, and causing many other diseases. And given, what is the point of this thing, right? Because it might seem that this is just a linguistic thing, a nomenclature, but this is really kind of a fundamentally different way that we think of a condition where 70% of us actually struggle with this. And just to repeat, things from last week, but as this food system moves everywhere in the world, out of 8 billion humans, more people are dying of diseases of too many calories than too few, right? So if 7 out of 10 humans in a given environment struggle with something, it clearly is something going on systemically in something of our bodies that does this, right? And this chart illustrates that there's such a heavy contribution of genetics. We've actually found more, 100 gene variants related to excess weight. But I think really the second bullet point right here that talks about how it's a complex interaction between genetic, behavioral, environmental influences, epigenetic changes, and everything else that really contributes to this issue. So I think the best way kind of to think of it logically is that for hundreds of thousands of years, our bodies were evolved in a caloric deficit environment. So they had to get really good at surviving on very few calories. Because really, in a world where there weren't 14 McDonald's between here and anywhere else, humans had went through periods of starvation and famine chronically, right? Whether it's the ice age or during history, the wars, poverty, everything else. Um, that required, the ones who survived, the ones whose bodies got really good at storing calories on their bodies as long as they could. And when they started losing weight, having all these mechanisms to prevent further weight loss and storing it until a time when, the famine resolved. So the thing is that in the last 70 years, we as humans have inadvertently created this world where we have the most energy dense, the energy efficient, addictive, and ever present calories, known to humanity. And it makes complete sense to me why, when they're so addictive and they're so just efficient in terms of when we eat them and how much we absorb and store of them, why this is such a biological issue. And I think it's just really important to fundamentally understand this and deconstruct some of the conditioning we've all had growing up, right? Like from all of the comments that were made, again, I struggle with this as a kid, so I know this, I've experienced some of this, but I've, seen more than 1,500 people now with this issue and seeing all of them in their lives and taking detailed way histories. And you just see like the way that we've been conditioned in this world to not like to occlude this fact, right? That there is some element of us, there's some willpower element, there's some value element, there's some discipline thing, but it's just that's not the way it is, right? Like in my data set of patients I have, there's very few that are actually just like eating fast food every single day or some of the other stereotypes of this. And you see how many people are struggling. I have a patient who just had such detailed accounting of everything. And it's like, I think she's just the perfect example of how it's so discordant in what she's eating and how much she's struggling. So the only way to truly understand this as a disease, and that understanding is important because everything flows from that in how we treat our patients. So with that, we will start with a case study of Mr. J. So he, presents to the clinic, complains of being more lethargic than usual. He has a history of obesity, diabetes, hypertension, hyperlipidemia, metabolic syndrome, basically, OSA, fatty liver disease, gout, arthritis, non-obstructive cardio CAD. She's on metformin, amlodipine, the SGLT2, glimepiride, rosuvastatin, allopurinol, losartan. This is a very, common picture of a lot of patients we treat. Right now, as an internal medicine physician, this is a very common thing I see in the clinics and the hospitals, right? So I think often, and we'll go through this case study, we think of all of these individual problems, right? That's how do we treat the blood pressure, the cholesterol, like the CPAP for the sleep apnea, right? All of these things we think about. And I think that really fundamentally thinking of what is some of the root causes of the issues and treating that is going to be really the key of how we, practice medicine as we keep going. Lab workup, for Mr. J shows an A1C of 8.1, blood pressure elevated 150 over 90, LDL of 120, triglycerides 360, his BMI 34 here, some transaminitis indicative of fatty liver disease, and coronary artery score of 199. So we see all of these issues, and again, a very common picture of all of our patients, of a lot of our patients, sorry. So how do we determine risks, right? BMI is one metric. We talked a lot about this last week, in that, BMI is just simply, just to repeat a little bit, all it is weight corrected for height. It's a way to take a population. How do you measure health risks in a population when everyone's different heights? You put them in a formula, you put them on the same line. However, that doesn't capture the entire story, right? So what else do we use? I mean, one thing it misses, again, for the people in here, just differences in ethnicity, right? For brown folks like myself, it's especially cruel because a BMI over 23 is considered overweight and 28 obese. But other measurements are waist circumference, right? So we can see in terms of waist circumference that it is a little bit different, with class 1 obesity, which we call 30 BMI 30 to 34, the waist circumference for men over 102 centimeters and 40 inches, it can change from this high to very high risk stratification. So Mr. J is here, BMI of 34, waist circumference, as we can see, so it puts them in, that very high category, which may trigger us to treat even more aggressively. Although, again, I would argue that just having a BMI over 25 with some of those other health metrics should trigger us in the very first place. So, when we talk about treating obesity, right, like why do we talk about it and how is it related to everything? And I think this chart shows that the astonishing amount of gains we get from just even a little bit of weight loss, right? So we get 3 to 10% weight loss, and you reduce, the prevention of diabetes. It's actually astonishing. I've had patients, their A1C, their fasting glucose drops so fast with just a little bit of weight loss, right? We get improvements in blood pressure, in dyslipidemia, in hyperglycemia, in fatty liver disease, right? Like there's so many studies and everything being proposed, like how do we treat like fatty liver disease, like vitamin E, just obviously that's an old one, but just weight loss, right? The answer is weight loss in so many cases, with improvement in this disease process. That's the number one cause of cirrhosis, right? Sleep apnea. Again, 10% weight loss can dramatically improve it, right? And actually with sleep apnea, it's pretty interesting. It's kind of very circular because I read a study where, just irrespective of calories, sleep apnea results in difficulty losing weight. And so, weight loss, can help, improve some of those metrics, sleep apnea, which can help with fatigue, cardiovascular disease, and all the other things that come with it. And then osteoarthritis, and the study is 5 to 10%, but I've had patients just lose a few pounds, and report dramatic improvements in their joint pains, just walking up the stairs. And that's like huge quality of life. That's like incredible quality of life. And I think that, we underestimate kind of just the psychological effect of chronic pain and people's lives when, you can't really move, your knees hurt, you can't walk, and that makes you feel worse, which again, when we're surrounded by this environment full of all this addictive food, it makes sense as a human human, we seek to escape from suffering. It's just this negative cycle, right? And so this weight loss can instigate a more virtuous cycle where you lose weight, you start moving more, you start doing things, you start being with your family more. You do activities, whereas you couldn't go to the beach because you couldn't run around with your kids there because of this issue. And you get people to lose a little bit of weight, and that affects all these other metrics just by itself, right? This quality of life. Stress incontinence, GERD, PCOS, just that's a huge aspect in fertility and everything. And in fact, we're going to talk a lot about the medicines, but they've shown an increased rates of fertility now because, just we've gotten people to lose so much weight with these medications. So how do you choose between the medication options, right? So there's multiple factors. There's drug factors, provider factors, and patient factors. So when we talk about the drug factors, we're going to go through some of the efficacy, safety data, and the benefits. So this chart was made prior to some of the newer studies, which study these medicines specifically for weight. But as we all know, they initially came out for diabetes. And I do want to clarify, these medicines are pretty phenomenal in that the GLPs trigger the beta cells to release insulin only when your blood sugar is high, right? And so they were actually at lower doses tested initially for diabetes and ultimately at higher doses found to be very effective for weight because they emulate our fullness pathways, which we'll talk about. But for weight loss is very high with semaglutide and tirzepatide. The first medicine in this category was liraglutide, which is a daily shot. Known for diabetes as Victoza, for weight loss as Saxenda, but a famous New England Journal of Medicine study showed how semaglutide was way more effective than liraglutide. The thinking between the newer medicines is because they just have way more interactions. They're able to cross, they interact with the brain. They have way more receptors, which they're able to trigger in the brain more. But these medicines are just, again, part of this new revolution in everything that's going on. So these are the semaglutide studies that Novo Nordisk did, and these are all the different steps, right? The steps are the step 1, 2, 3, 4, 5. These are huge ones that talk about weight, and the SURMOUNT studies are the ones with tirzepatide. So as we can see in the step 1, 2, 1, 3, 4, 5, we see we're getting up to 14%, 16% weight loss, right? We're getting radical amounts of weight loss. It is interesting in between, I believe it's the step 1 and the 3. One of the studies had a much more intensive intervention, but they didn't actually show actually differences. My argument to that is, I have to see like what are the types. Not every behavioral intervention is the same, but when these studies did come out, I mean, 15%, like 16%, these blew every other medication out of the water. Like that's why it was such a phenomenon, right? That's why it's triggered this phenomenon. Because like before, if you can get someone to lose like 5 to 10% really with anything, it was just unheard of, right? That was like good. Now, like those are just table stakes. Like so you can see in the second column over here, or in the fourth column, like 86% of people lost 5%. Like that's just table stakes now, right? That's nothing. So like getting to like 15, 20, 25%, like this is the future, right? And that's where tirzepatide came in, right? Again, the semaglutide emulates one side hormone, tirzepatide 2, the GLP and GIP, but we're getting up to 20% weight loss here, right? 20, 21%. These are just amazing, amazing compounds. And so we just have to see like we are in a golden age of this, and we're just at the beginning of like this. And after, I mean, it's just so refreshing, so like I said, I got into this industry, this field before it was cool, before these GLPs really came out. But of course, I got graduate training in 2013, but the history of weight loss of obesity medications is decades old with multiple failures, right? Especially with like fen, which was like basically traumatic for the field. With fenfluramine being pulled out and it gaining, consciousness within the public, it created like this huge cognitive distortion in everybody that like, oh my gosh, there's nothing that can work. The other shoe is going to fall. And a lot of that thinking, I think, is behind, kind of some of the apprehension sometimes of these new medications, but also other like studies like of leptin. When we found that pathway and we were thinking, oh, this is going to work, but the leptin resistance, show that it didn't. So when all of this came out now, and liraglutide came out in like the early 2010s. So these medicines, and now we're having huge studies with improvements in cardiovascular. We'll talk about that a little bit later. But it was just basically showing over and over again the effectiveness and safety of these medications. And I think like, medicine, it just needs to herald these developments, because the status quo sucks, right? Again, those statistics I keep mentioning over and over, it's like we have a record number of people dying of heart attacks and strokes like all the time, right? We have 70% of us struggle with this. The status quo is we have allowed these food companies to have like a billion types of M&Ms around us every second of the day, right? Like what is the result of those like that? I don't think there's like a big societal conversation like should we allow, what's like a Nestle or Frito-Lay's to like keep introducing new chips, and what is the result of that? So it's just really important. I really want to stress to everybody that this isn't just a fad, right? This is not just something, this is like scientific, evidence-based, straight up medicine, right? This is proven through multiple studies, through arduous research of effectiveness, and we're going to go into safety. So it's just, I really want people, one of the points is to feel very comfortable with the use of these medicines, just because of the overwhelming amount of data now. So, on March 8th, so this is this new study that came out, that like it showed, this is the largest, I think we have it here. We'll talk about it in a little bit, but this is the largest study on weight loss medication that's actually ever happened, right? In this March 8th, 2024, we got the indication to reduce the risk of major adverse cardiovascular events. You can use these medications in either obesity and overweight. And this really is important, right? Because you're still testing, you're still using these medications in patients with BMI over 30 or 27 with a comorbidity. But it's important because how insurance coverage works is that they put these medicines in a separate bucket, right? So obesity medicines are placed in a separate bucket, and it's different than kind of other medicines. And so it's whether you have coverage or not of that. And that's kind of, irrespective of the traditional vectors of this, whether you have PPO, HMO, or whatever, it's whether you also, because most of us get it through our employers, right? So it's whether your employer had selected that obesity medicine coverage. And so, and then Medicare does not have that at all. But this indication allows us to get these medications approved through a separate bucket, right? That we can get it approved through this cardiovascular risk assessment. So, these are the studies. This is the chart of everything that just kind of shows the percent change. And we see, basically how these studies usually work is they have a period where a dose escalation period where they titrate people to the highest, over a few months, they titrate to the highest dose, and then they randomize them. So this study in step one randomized to placebo or the medicine. And then over the next 68 weeks, they saw this beautiful over 16% drop, right? Again, phenomenal. This is blockbuster, right? And these excluded diabetes. And then we have the surmount, which is tirzepatide, right? And they tested the different doses. They had different arms, 5, 10, 15. 15, we got to 22% weight loss. Again, previously unheard of, right? So all the hype that we hear about it is 1,000,000,000% justified. It is just, these medicines are just, I can't speak so highly enough of them. So then we have the Surmount 3, and I think the point of this, this is the initial study where they tested the medicines with obesity and type 2 diabetes, and again just showing the drop in weight loss. So this was the initial study that got tirzepatide, known as Mounjaro, approved, and then subsequently the study for the patients without diabetes that got tirzepatide approved for weight loss, which is called Zepbound. But this just shows like its data on A1C as well. We dropped from 7.82 to 5.76, 5.85. In my opinion only, but I think that a lot of this is from like this beautiful weight loss, right? You just improve the amount of weight, and it is, the cure for, or like a much, the best treatment for insulin resistance. And then we have, presenting you the Surmount 3. And this is the one that I was pointing to without diabetes that got the Zepbound approved. But we see this weight loss, of this 18%. And then we see, this 21% down here after the randomization again over the next 72 weeks. So it's just completely amazing results in all of these medications. And then these are the other benefits, right? Besides that, so we already talked about, the benefits in A1C that we've gotten with all of the, semaglutide at 1 milligram, which is not, the highest dose is 2.4. So this was the initial highest dose of semaglutide, which was indicated for diabetes, called Ozempic. And so we got that. And then we have the different doses of tirzepatide, and all of them 8.2. And again, the beautiful drop of this, like the 5.82, just amazing stuff. And the lipid levels we see here, see a nice drop in the triglycerides, right? This dose dependent, kind of relationship with the tirzepatide. We have the HDL going up, we have the LDL cholesterol going down. Just very nice results. Again, improving cardiovascular health in all these people. And then with NASH, right? So we see this semaglutide study, and the resolution of NASH with no worsening liver fibrosis, at the various different doses. We see like this, like 59% of the participants. And this is where this was more qualitative, this is more quantitative, right, with the tirzepatide. And we see kind of, again, a nice drop in all these numbers of the amount of change of liver fat, content. So these are all like subgroup analyses. It wasn't like made to test these, but they did see these in these subgroup analyses. And then this is a study I was talking about with the cardiovascular risk outcome with right here, semaglutide. And this one was the biggest weight loss study that's ever been done in anything. So this was, a trial of 230 sites, 20 countries, right? Just like 1,600 patients in the medicine arm, and 1,649 in the placebo group. And you just see like the nice, like kind of separating of these lines as we kept going. And the interesting thing is the separation starts very early, right? It starts like starting, at 16 weeks even. And this is, the study was not like, does not really, we don't know the mechanism. So this is kind of just conjecture and kind of like what people think, expert opinion. But, it does suggest, based on physiological and biological studies, that there is some anti-inflammatory component of this. I think also, though, there has to be some component. Again, I'm speaking like just, again, conjecture and based on, kind of some of the other kind of data that I'm talking about. But, there must be something that has to do with how it changes, and just, my clinical experience, but how it changes what we eat, the decrease in our ultra processed foods, our cravings for alcohol, all these other things, right, that are also the downstream effects. And, again, the social elements. And, it's based, some of my thinking is based on when we study like these blue zone people, and we see that it's more complicated than just like, just calories in, calories out. It's just community. There's like a bunch of different factors that relate to overall health. And so I think, a lot of these medicines are kind of like, there's other downstream effects of what's going on with the medicines as well. And then this is just tirzepatide, and this is just using pool data, and they've seen some of the same, this study in the surpass, this is just kind of like an analysis of pool data. The study wasn't necessarily designed to measure cardiovascular death like the SUSTAIN was, but it does show, a similar type of phenomenon. So, what are the side effects, right? How I tell my patients, right? Nothing is without risk in this world. You drive your car. I think already we have 45,000 car accidents every year. And I'm sure, we all know at least of stories of unfortunate, tragedies happening with that. We drive all the time. But I think that, these medicines are, in my clinical opinion, very safe, but it is important to talk to your patient. I talk to every single patient about these things. So, what are the effects? 3 to 5% abdominal pain, constipation, dyspepsia, vomiting, diarrhea, nausea, right? Those are kind of the main side effects that we see. It's important to talk to our patients about these things and talk about strategies. However, as we talk about in subsequent slides, our medicine, we actually get used to these medicines and our body gets used to the molecules and the side effects, diminish. But I also say we weigh risk benefits, right? What are the risks of, sorry, someone crash, not accidents. Um, so maybe we can elaborate on that later. But so I think I always say we weigh risk benefits of everything, right? I mean, I think we should do that with every intervention we ever do. And I say, what are the risks versus what are the risks of not intervening, right? And as we've seen in these slides and all of our experiences, right, there's a huge risk of excess weight and obesity. And so I think it's really important to kind of weigh those risks together when making these decisions. Um, okay, so here, these are just questions from the community, and I'll answer them as we go through the slides. But are there any contraindications with these medicines? Are there certain patient populations who should not receive these medicines? So, the audio was just saying that. So, the contraindications, right? The black box warnings is a personal family history of a very specific type of thyroid cancer, medullary thyroid cancer, or patients with multiple endocrine neoplasia syndrome type 2, and obviously any hypersensitivity interactions, right? Those are like the straight up black box contradictions and very specific to those two things because they are thought to be triggered by GLPs. This is based on mouse studies specifically. There it hasn't been studied. Pancreatitis is kind of a softer kind of thing, and it's not because it wasn't studied with type 1 diabetics. So those are kind of the official contraindications and more limitations. I think the limitations, especially with pancreatitis, in my clinical opinion, if it's something like gallstone pancreatitis and people have their gallbladders removed, I'd be probably more inclined to treat. If it's like history of like alcoholic pancreatitis, people who have been sober for a very long time. I think it's case by case. I wouldn't use that as a necessary contraindication, but again, it's important to really assess our patients, really make sure. So birth control options. So the only thing is these medicines slow down our GI tract. So anyone who's on oral birth control, it could affect, some of that. So I always encourage people to talk to their OB-GYNs. So anything that's non-oral, like IUDs or any, injections or whatever, that is a more viable option, or using a secondary, like condoms or something. A secondary method also is probably, but that's another important thing to talk to patients about. But anything orally, and specifically because it slows down our GI tract and it could change the absorption patterns of it. So that's something to keep in mind. So that's an excellent question. So, what is the worst call about a side effect I can expect from a patient when I prescribed a second generation AOM? I want to be prepared for the worst case scenario to feel comfortable prescribing these medicines. So, excellent question. So, these are the warnings and precautions. So, pancreatitis, hypoglycemia, if you're using another, insulin medicine, hypersensitivity, acute kidney injury, severe GI disease, diabetic retinopathy complications, gallbladder disease. So, I've treated more than 1,500 people. I mean, in terms of my data set I have, is really the number one main thing is, severe constipation. I haven't actually had any ileuses or SBOs. And through the years, I've just gotten much more aggressive about asking and treating constipation and dosing the medicines appropriately. And we'll talk about it like slowly, like, either decreasing the rate of increase or actually decreasing the medication. So that's the thing I'm really, really attuned to. I haven't actually had any acute kidney injury, although it is in the warning label. I think, it's thought to be specifically when in patients that are not, drinking anything or like drinking less water. I've had like maybe 3, 4 cases of cholecystitis. So weight loss itself can cause cholecystitis, but GLPs do slow down your biliary tract. So there's some, beyond that, the weight loss effect. Just again, this is all my clinical opinion, but the 3 patients who had cholecystitis, they got their gallbladder out and then they chose to go back on the medications. Pancreatitis, I might have had 2 cases of pancreatitis, and there were very low levels of elevation in lipase, which quickly resolved. So I think those are kind of like what I see. But again, I think the main thing really is the severe constipation and just really monitoring that. And that's just, like follow up and just asking about it. And really, either going down on the medicine, slowing down, having a good bowel regimen, vegetables and everything. I think those are things in terms of answering that specific question. So what is and we'll save the question. If there's any questions, feel free to put them in the chat or we can talk about it at the end. So, what are so we talked about the drug factors, now let's talk about the provider factors, right? So, provider knowledge, comfort, therapeutic inertia. So, why do they exist, right? So I think understandably. So I have the privilege of my clinic is called Mindful Wellness. I forgot to introduce myself for people who weren't here last time, but it's called Mindful Wellness. I practice a concierge-based model where I see my patient for an hour initially, have unlimited 30-minute appointments. But I have managed a PCP clinic in the past and PT, skilled care nurse, and like worked in the healthcare system. Right now I'm managing another insurance practice as well. So I understand like that's impossible, right? Like I have the privilege of being able to see people for an hour, but I think there's still models that we can do and I think if we get more familiar with it, then we can still, incorporate it within some of our normal processes and maybe have, prescribe like specific appointments for this within a PCP that are independent at a different time, or, having NPs or health coaches or other allied professionals helping us manage it. But it totally understand it's completely valid. But I think that if we can figure out and think creatively to really change some of our patient flows, this can help, our patients get better in a lot of different ways and, help with, some quality measures that we are, in a capitated system, if you guys are practicing a lot of that, which a lot of us are now, but, help with some of the star measures, some of the quality measures, all the things that can help also with, incentives and reimbursement. Lack of comfort, again, these are new and I didn't learn anything about before I got bored in obesity medicine. I'm an internal medicine physician. I didn't learn anything about nutrition or like medicine, these medicines or anything. So this is why, this community collective, like we're trying to do these talks to try to get to address that issue. I told them to add this. This is probably one of the biggest issue, insurance coverage and supply issues. We can talk any questions at the end or next week, probably in person would be the best venue to talk a lot about some of those issues. And then misconceptions around pharmacological treatment. I think this is still a big one, and I think that's something that we really need to address. It's medication is less effective than lifestyle. Weight loss medications are not safe. It's only a short-term solution. So these are all false in a bunch of different ways, right? Like in multiple studies, we've seen medication is actually like more effective, but I would argue more that you need everything. What's more effective is doing both, but still medications because of the fundamental biological issues and all of the, like what we call like in another time biopsychosocial stuff and genetic epigenetic things, right? These are, the status quo of all the lifestyle interventions, only education programs have not been working, right? So these medications really address a lot of these fundamental things that have made this hard for a lot of our patients. I hope the safety issues, we've presented kind of some of the data around that. But I'd love any more questions to help address some of that. In the short-term care solution, I mean, we've defined obesity, which is correct, as a lifelong, recurrent disease. And I think just in our lived experience, we can see, patients or people in our lives or something you try so many times. And we talked about it last time, but just for people in here, I think the fundamental thing that, one of the best studies is something we call the Biggest Loser study, which is that tested people who lost a lot of weight from that show. And then 6 years later, they tested them and they found that the ones who were able to, maintain their weight, their metabolic rate, they had to eat around 600 calories less just to maintain their weight, right? Just to maintain. So you can see how demotivating that is if like everything you're doing is working, and then you have like a weekend where you go out or vacation or something, you start gaining weight, you go, okay, I'm gonna try again, and then something else happens, and it's just like, oh, screw it, I've been trying so hard, and it just keeps going, right? It's just not. This is a long-term thing, like this disease process, and medication is a vital part of this. And so patient factors, right? Preferences, adherence, and access. So,
Oh, okay. That makes sense. What about the side effects? I read something on Facebook about these medicines that I didn't like.
yeah, so this is just talking about, some of the questions that patients have that we should be ready to answer, when our patients ask
Oh,
us.
okay. That makes sense.
Sorry.
What about the side effects? I read something on Facebook about these medicines that I didn't like.
Okay, so these are the side effects, right? As we talked about, nausea, GERD, constipation, diarrhea, dyspepsia, fatigue, and vomiting. So before we talked about the more severe side effects, and now we're going to kind of get into more of the everyday side effects, right? We have, gas, gastroenteritis, headache, belching, abdominal pain, abdominal bloating, right? These are all the things that we talk to our patients about. So, going through the studies first, we see how, as I mentioned before, that as we use these medications more, those diminish, right? So we see in these studies, again, they study these in different arms, the 5, 10, and 15, and then also the semaglutide at 1 and the other study, we see as we kept going how the percentage of nausea, dramatically improves, and our body gets used to these medications, right? These molecules, and that nausea feeling decreases substantially, empirically, and also in my clinical opinion, I see. In most cases, are very mild to moderate transient. I think it's really important. And so, as an internal medicine doctor, I use a lot of different medicines. In my experience, as this obesity medicine physician, use fewer medicines, but use them in like a lot more patients. And you just see how much human variability there is, right? I have patients who are exquisitely sensitive to these medicines, and I have patients who ramp them up all the way and everything in between. So it's really important we treat our specific patient and we see how they're responding to it and adjust our dosing strategies based on that. But as we use the medicine more, our bodies get used to the molecule again, and the nausea feelings go down. And then this is talking about the tolerability of like studying, nausea, diarrhea, vomiting at the high dose of 2.4, and you can see that the placebo, and you see the semaglutide, and since the weeks after people started on the high dose, you could see how the rate of the proportion of participants who experience these things continue to go down. And you know, we see how they're, mild, moderate, and temporary, and then we should dose these medications. There's the way people are eating, right? So remember the way that these medicines work is they slow down our GI tract, right? So a way to accommodate, to help some of it is to, smaller meals, eating slowly, just kind of like really of doing things to kind of avoid the abdominal distension feeling as much. And that can really, really help some of the symptoms people are feeling. So just continuing on this case study to help keep illustrating the point of what we're talking about.
Oh, okay. Okay. I will take it if my insurance covers it. But do I have to take it my whole life? What happens if I stop taking it? Oh.
Okay. So the answer to that question, so first let's talk about the slide real quick, is that, again, this is a chronic disease. Like as we've talked about, it's more complicated. It's not correct to say this is like a willpower thing or a discipline thing. There's a bunch of factors, including genetics, society, stress, sleep, the epigenetics, right? It's like just basically our epigenetics can turn like various like different genes on and off. So we have to think, just to spend a second on that. Our epigenetics, like our genes are the DNA, of course, that codes for the proteins that are transcribed. But the epigenetics are also like if they're methylated, which genes are methylated, how much they're wrapped around the histones, that's like another factor. Like it's just basically we have to see how like our system is that there are multiple points in this that can each add more permutations of ways that those proteins can be transcribed. There's transcription factors that can come when our proteins affect our extracellular matrix that go into our cells and our nucleus. So it's just given at the genetic level how complicated it is, not to mention afterwards, how we're raised, and just what food is around you, your food environment. Like if you have parks near you, whether the types of food you have. I had a patient, I'm in LA, I have a patient who literally like told me, the Ralphs in Inglewood, they did not sell like grilled chicken, right? They had a ton of fried chicken. They didn't sell any rotisserie chicken. And whereas if you go to Manhattan Beach, you went to Manhattan Beach and there's tons of it. So it just like all of these factors have to do with it. So again, contributing to this idea of obesity as a chronic disease. I think otherwise, so just like, you treat, you have a relationship for diabetes, hypertension, it's the other thing. I do want to kind of just put a little bit more nuance to this in terms of how I practice this, in terms of I go up on the medicine and then I titrate down and it's different, right? Like, having treated all these people, you see that how people's lives just change through, with everything, right? You see how we establish some homeostasis with our world and we have a certain life, and then we get a job, right? We get promoted, we have a commute, we get married, we get divorced, we get like our kid grows up, goes to college, it changes. We have all of these things that happen that change all of the ways that we do things, different routines. So these medicines help us establish a new homeostasis with our current world, and then things may change. So you could take people down on it, like take them off, put them back on. It doesn't have to be just on and off with everything. So okay, so I answer the questions at the end. I apologize because we're almost there. So then next one, okay, let's talk a post-test question. So to facilitate shared decision-making, what counseling and education points would you provide a patient regarding second generation AOMs, allowing them to make an informed decision about their therapy? So A, GI adverse events are mild, but do not typically go away over time. B, they can only take second generation AOMs for no more than 3 months. C, obesity is a chronic disease. This therapy will help adjust your physiology while you take it. D, you don't have to worry about your diet, and these therapies will make you naturally eat less. So I think I messed up on the first post-test question. Or is this the first one? No, I think I messed up on the first one. So
Marissa,
I think
can
the
you
wrong
run
question.
that one again?
Yeah.
This is 3. Yeah, there we go. Yeah, this is the same question here.
So everyone just go ahead and fill this out. Yep. Got one answer. Okay. I think everyone on this call is probably really good test takers. So going through medicine. So that's clearly, the right answer in this question. So, again, it's a chronic disease. Okay. So this is how you escalate the doses. And semaglutide, we have, brand name for weight loss Wegovy, 0.25, 0.51, 1.7, 2.4. These are all individual pens. When you prescribe the medicine, you get 4 of one type of dose. So it's just like pre-loaded pen needles. So all you do is you just put in your skin and press the button, and the syringe goes in and out. They're very easy to administer. And so 0.25, 0.51, 1.7, 2.4. Tirzepatide is just in increments of 2.5, starting with 2.5 to 15, right? So this is the ones that they've used in the studies. But again, how I dose it, and I think how they should be, it should be dosed to the individual patient. And so, if someone is losing like a good amount of weight at 0.5 and, it continues, they're having minimal side effects, I wouldn't go up on that patient. So, conversely, if they're not and they're going up, or conversely, if they're having a lot of perhaps, side effects at 1.7, maybe they're feeling very fatigued and stuff, I would go down on the medicine actually, and, try to get them, more used to the medicine before going up again. Okay, next question. A second generation AOM was initiated in your patient 2 weeks ago. They report that they have been experiencing some GI issues. Which of the following is the best way to manage these common side effects? A, switch to glimepiride. B, titrate dose slowly. C, switch to PO semaglutide. Or D, change to a shorter acting agent. I don't know if the question was pulled up, guys. There we go. Okay, perfect. So most of you picked, titrate dose slowly. We had a few switch to PO semaglutides. So that's a good, thought. You know, PO semaglutide is interesting. Right now it is branded for diabetes only. It's called Ribelsis. And, eventually, Novo is testing it at or higher doses. Right now it's 7 and 14, and they're testing like 21, I believe, almost, I think 50 in one of the studies as well. So I think that right now, titrating dose slowly is the right answer. But as after we get to the weight loss approval for PO semaglutide, it may be an interesting idea, although in the studies, PO, and in my clinical experience too, one of my patients, PO semaglutide actually has more GI issues, right? So in the studies, it's shown to be more. You have to take it daily. It's 30 minutes. It's like thyroid medicine, you have to take 30 minutes to start eating. So I'm pretty skeptical of PO semaglutide, but as it becomes more available, I just want more of an armament to treat my patients. There's people who are deathly afraid of needles, for example, and PO semaglutide might be a great option for them. And also every body is different, so it's not necessarily untrue, right? Some people may experience less side effects with it. So I think it is a good thing to think about, as right now, though, we can only, Ribelsis is kind of the only option, and that's not necessarily FDA indicated for diabetes. I mean, an insurance company won't cover it unless you have an A1C, at the right range. So it is something to think about, but it's an interesting thing. So just moving on with the case study. After confirmation that Mr. J's insurance covered tirzepatide, he began dose escalation 6 weeks after initiation. Leaves this voicemail.
Doctor, I'm sorry to bother you. I want to see if you can help me with some nausea that I've been having when I started on the higher dose. It's not really bad, but I don't want it to get worse. Thank you so much for your help, and you have a nice day.
Yeah, so Mr. J is a very sweet patient. He began initiation like 6 weeks after initiation. He has it. Again, it's hard in a traditional medical model, but I would recommend after initiation kind of seeing them in the first month, if you can, just to see how they're tolerating it.
Doctor, I'm sorry.
Sorry.
Doctor.
Okay. So, the algorithm in this PowerPoint, I think I kind of use a more individualized rather than having an algorithm, but I think it's still helpful, to kind of go through this. So, if in Mr. J's case, for example, if there's, some dose escalation and they have some of these side effects, these adverse effects, and I think slowing down is really the right answer. I think maybe for people who are, entering the field, this may be helpful in kind of thinking about it, but, you could extend the current phase 2 to 4 more weeks. You could, suspend it and kind of give them a vacation from it. you could go back to a dose, a lower dose, and I think that could be an option. Otherwise, you could. So I think in terms of the dose escalation, um, seeing if they keep having it, make sure nothing else is going on, talking to people about the dietary guidelines, talking, and then of course, and what I do all the time is use antiemetics, antidiarrheals, and stool softeners. So, sorry, I forgot to mention earlier, but constipation is the main thing, but certain patients do have more loose stools. But yeah, antidiarrheals can be used for that. I like using a lot of for that specifically, Metamucil for bulking agents for both actually diarrhea and constipation. But for constipation, I use Marilax or Colace. I kind of have an algorithm where I use stool softener like some Colace and maybe some fiber, Metamucil, and then some motility agents like Dopalax, perhaps if 2 days they're not going to the bathroom. I like using Zofran primarily, but you can use some prokinetics also for nausea. And then, severe cases, may require some IV rehydration. This isn't very common, especially if we have really good monitoring of our patients before they get to that point, and we can go slowly and adjust the medicines before they get there for really all these 3 GI effects. So, at 12 months, it's a great study, 24% weight loss, able to get them off some of the diabetes and, blood pressure medications. And you see this beautiful drop of, fasting glucose and amazing, like this is I just love when this happens and the A1C just drops so nicely. Blood pressure, I think this is an important point. I like how this example points this out. LDL is a little bit less amenable to weight loss. So it is something I always tell my patients that as well. There's more of a genetic component to that. So it is something to remember. So if you don't see it, it's just something, it's a very common experience that the LDL doesn't drop that much. And, they may require still a statin or another medicine as well. Just as an aside, the only diet that's really been shown to really help the LDL is called a portfolio diet, which is mostly a plant-based diet. So it's just something to know. Of course, it's hard to adhere to a lot of patients, but the triglycerides drop really nicely, very fast, as they did in this patient. As you see, the weight, BMI, waist circumference, the transaminitis, all of it. So it just shows how amazing results you get and how the treatment of weight really results in the treating of like a billion other disease processes. And it's just absolutely phenomenal. And I see this every day and I describe this work that I do. I think I forgot to say this last time, and I apologize if I did say it, I'm gonna repeat it. But my work as a hospitalist, I see people in the hospital, and you see them after decades of elevated blood sugars and blood pressure, and you see the sequelae of the heart attack, strokes, kidney disease, everything from that, right? And so you see that at that point, but this is like ultimate preventative medicine, right? You not only, treat some of these health metrics, but you change like often people's relationships with themselves and the world. You change, like you prevent that heart attack in 20 years that has an effect on their kids, their marriages, their spouses. You make them feel better and you create more like their relationship with their jobs and their community. And it's just like, it sounds very grandiose, but it really feels like you're doing such a big thing by doing this work. And it's just, I can't describe how immensely gratifying it is to do this. So other questions from the community, I think there's only 2, and then we'll answer any other questions you guys may have. But how do I handle a situation where the patient wants medication for weight loss, but hasn't tried to make any changes in lifestyle like diet? And actually, I love this question. One person actually answered this to me directly. And I think this is just reflects kind of our conditioned fundamental, what I call the willpower narrative, right? This is just not the way to think of this, right? Again, this is a disease. There's, which I've mentioned so many times, there's all these factors that are doing it, and the status quo does not work, right? I think this type of thinking is more like, oh, like there's a certain few that deserve this, right? And I think it comes from insurance criteria, for example, of weight loss surgery, right? Although, I know I've read studies where that insurance criteria of losing weight is not necessarily as helpful even for weight loss surgeries. And so I think that again, it's just kind of this, it really like triggers me in the wrong way because it's such a moralistic way of looking at this. Like, does this patient deserve to have this amazing treatment, right? No, these medicines help us do those things, right? They take the edge off, they turn the volume down from all of these stimuli and food noise that we're like, that all of our patients are dealing with to be able to do these things, and improves things like joint disease and osteoarthritis to be able to do some physical activity, right? And it helps us not like, stop at the McDonald's on the way home, because we feel anxious about like a hard day, or that like, not pressing the DoorDash button when, we, are just tired and exhausted, right? It helps us do those things. And so it's such an inverse of the way we should be thinking of this. Number two, how can be sure to be reimbursed for an obesity visit? How do I know what to correctly bill for? So this is a more difficult question. So I have more experience in more of the kind of cash-based model. But, when I've talked to my colleagues and everything who practice this, unfortunately, there isn't good like specific things, for obesity. I know Medicare has some right now, but really just billing for all the other chronic diseases is going to be key in these visits. And I think there's some counseling visits also for Medicare, but we can, if someone has, a question, just email me about any of this and I can find out more information. I can give you more specifics about how to be reimbursed in the most optimal way. So that's the talk. I'm just gonna keep this up here and then I'll just look through the chat. So if the Biggest Loser folks have to eat so much less to not gain, how many calories do people need on these meds take in? Probably the same. They just aren't hungry. Otherwise, I'd guess the meds would need to change our metabolism, which I haven't heard anybody say. Sorry, I wasn't able. Sorry, that's sweet. Okay, so I think that the Biggest Loser is one cohort of patients, right? They studied it. I think it's just more reflection of like that population of patients that show that this metabolism effect is working. I like that it does not change their metabolism. There's no evidence it does. I mean, maybe some tirzepatide and GIP, but nothing definitive. I think that it is, these medicines help us through that journey of decreased metabolism, right? So like it's different for different folks also, but like if it helps us have that 600 calorie deficit like 6 years in, if you were to use it at that example, right? I think that really there's other things we do, like at least in my clinic, we talk about like, getting enough protein, resistance training, because building muscle is one thing that does increase our metabolism. So there's other things we talk about. We talk about how to actually make this sustainable. And also one thing is calories are not everything. So calories are, I would talk about it in two ways. I think it's important to understand how like calories are measured. Calories are measured because you put food within a machine called a bomb calorimeter, blow it up, and the heat amount that is generated is the amount of kilocalories, shorthand we call calories, that's generated. Our bodies are not the same as that. When food goes into us, there's other factors in terms of, like if we eat a lot of vegetables with stuff that we eat, we don't absorb as much. If we eat more ultra processed food, we absorb so much of it. It affects like the best probiotic in the universe is fruits and vegetables. That changes kind of how the absorption patterns of different calories that we eat. So, I think that point of the study is just to illustrate that metabolism effect, but it's still more nuanced even when we talk about calories, right? So I really like to talk to patients about that because it feels like, such a, it can't feel like deprivation. If it feels like deprivation, it'll never work. So it has to be a slow shift in what people are eating, right? More than anything. So what is the data on what happens when people stop these drugs? I've heard about the regain, but it's different from regain that happens after dieting. So the answer is no. I love that question. So really, this is all based on one trial of Novo of Wegovy. And again, what they did with these people, they took over, I think, a few months. They titrated a group of patients to the highest dose. Then afterwards, they randomized them to placebo versus continued drugs. And they found that over the next 60 weeks, the placebo group regained 2/3 of their weight, right? And so I like to think of it, again, doing this intensive behavioral therapy I do, I see that, like, first of all, these medicines, if they do things like they help us build a habit of not buying the chips in the first place that we eat every day after we eat dinner, that's sustainable weight loss, right? But again, like the second part of the question is perfect. every way that we lose weight, you are likely to regain weight, right? Because these medicines do not burn the fat, right? As the other question Mike suggested, these medicines decrease our hunger, decrease our craving, increase our fullness, and that's the what results in the weight loss, right? So 100% these medicines, like in terms of that regain, it is more nuanced because in that study, there wasn't all of this interventions, the behavioral stuff, and like a few months when they escalated the dose to the highest dose of the 2.4 is not enough for any of that stuff. Plus, they went from 60 to 0. They dropped them from 2.4 to 0, right? The placebo group. Imagine if you're in a placebo arm, you're probably pissed off that like you're not getting the medicine. You get it's pretty like they were probably able to tell that they weren't getting the medicine pretty fast. So there's also some other factors that go into that. I think that if you use them with a more kind of nuanced understanding of them, we can think about ways to use them going up, down, taking them off, reusing them again in the future. So I think it's more complicated than like it's portrayed in the general media. Cool. So I think there's no more questions. So, I think next week, we have this beautiful in-person session, and it's going to be me and then my nurse practitioner, my health coach. So we'll be able to answer a lot of different anything. We have like now a lot of good experience in this field, and we've treated a lot of patients. So we'll be excited to see you guys next week.
Thank you so much, Dr. Gupta. It'll be great to meet you in person next week. For all the learners on the line, if you're interested in claiming continuing education credit for this session, for this wonderful presentation, please use the QR code on the screen or visit mli.link/obesity LAX2. Thank you again. Have a great night, and we look forward to seeing you at Bonaventure Brewing next week. Thank you.
Hey guys.
Thank you, Dr. Gupta.
Cool. So
I
how'd it
will.
go? Everything okay?
I mean, yeah, seemed great.